Okay, so it's now 4:20. I think what I'd like to do is give each of the participants at the table 5 to 6 minutes to give their impression of today's events, summarize to them what it means, identify any particular gaps that they may have identified in their presence in their listening to this. And we're going to wait for Linda D. to come to the podium here. So that's 5 to 6 minutes each for a little summary and any gap filling, and then we'll open it up for some questions and then adjourn. So the panelists that we have here, just for a brief introduction, is Linda D. is an attorney and president of the AIDS Action in Baltimore. Dawn Fukuda is the director of the Office of HIV/AIDS at the Massachusetts Department of Health, and is currently the vice chair of the National Association of State and Territorial AIDS Directors. Linda Lewis is a pediatric infectious disease physician and the medical team leader in the Division of Antiviral Drug Products at FDA and has been at the agency for 12 years. And Gina Piper is the Senior Medical Officer, NIH, Division of AIDS, and a member of the Microbicide Development Program. She's also the Medical Officer to VOICE. With that, let me turn to Linda, because I know as an attorney she can keep to 6 minutes.
I bet I can. Anyway, I didn't realize I was going to have to do a summary, but I think I can do that pretty quickly. I think while it looks like we're looking at great side effect profiles right now, I'm from Missouri, and come and see me in a couple of years, and then I'll let you know whether I think the side effect profiles have been established. I'm so used to talking to you, I'm getting nervous. Okay, so as I said, I think that for me, I want to see that continues, that bone loss stabilizes and stays that way and doesn't really continue to be troublesome. As far as the cost stuff, I mean, I like to combine this a little bit with Aetna. You know, I also work with a group called the Fair Pricing Coalition, and I really would love for insurance companies to say, okay, this drug costs too much, rebates or not. It's time for them. You know, there's the bottom line as to what they'll pay for. So, you know, if they all got together and decided, well, and I'm sure there are laws about that as well, but I mean, it's only them at this point that can say these drugs cost too much. I would like to say a little bit about cost, and I think that I alluded to this before. The Fair Pricing Coalition has dealt with in conjunction and collaboration with groups like AVAC and PI about what we should do about this pricing situation with PrEP. Should we have two different prices? Should we ask for a lower price across the board for Truvada for PrEP? So what we decided was, we're used to dealing with companies with regard to ADAPs. And what we do with ADAPs is they get a 340B price, which is about 23 to 40% discount rates. And they also get rebates over and above that. That substantially lowers the price of the drug. So we thought that Gilead, working with qualified federal health centers, giving them the 340B price, which they already get, and those deeper rebates would ensure that people in these the other communities besides the gay white community would also have access to this. We thought that as far as the demonstration projects were concerned, we've heard a lot about this today, and I think that it's very important to take a multidisciplinary approach with this, have HHS deal with the CDC and HRSA and make them work together to bring all of the services that everybody described so well today to bear for all the communities. I mean, I know what the rules are about competitions, but there's got to be some city somewhere besides Boston and San Francisco that can do this for African American communities. I think we all would agree to that. I'm trying to think of anything else. Is that 6 minutes?
You're pretty much right on.
Okay.
I'll take your extra.
Okay. Dawn, go for it.
Hi, my name's Dawn Fukuda, and I'm from Massachusetts. I'm the AIDS director there, and I can talk really, really fast, so 6 minutes for me is like 12. I've been thrilled with the conversation and the quality and the content of the conversation today, and I want to sort of reflect 3 questions I'm hearing, what we need to determine about PrEP. 1, does it work and for whom? 2, how can the healthcare system implement and sustain PrEP for the populations that need it? And 3 is not really a question, more of a comment, that demonstration projects are clearly vital. We have to make them happen. They have to be coordinated, which one of the earlier speakers commented on, that we need to be sharing information. And we have to have all those projects incorporate that if they reach a threshold level of success, there have to be plans for scale-up built into that demonstration project. So we need to ensure that all those pieces are in place. The other 3 things I've been hearing consistently throughout this conversation is, what do we need to do next to make sure we can accomplish what PrEP has to offer? And I heard 3 things. 1, we have to define core public health systems capacities. Like, by the way, healthcare has to be accessible to the people who need it. Now, in Massachusetts, I come from a state where we have successful healthcare reform, but I will still tell you that even in Massachusetts, there are members of our population, for a variety of reasons, who still don't have access to healthcare. We've got to figure that out, this core system capacity. We have to make sure there's adequate services. We have to make sure that there's adequate coverage for everything that PrEP entails, the medicines and the services that surround them. What I think Callie kind of started referring to is that essential PrEP prevention package that has to surround the medication and the prescription. We need to make sure we have adequate PrEP-savvy providers, both clinicians who prescribe it and also that support staff that surrounds the clinician who prescribes it. We need a health-literate patient population. If anyone has any ideas about how to accomplish that across the country, that's awesome. We need quality assurance and monitoring of the system, and we need solid laboratory capacities in our states and jurisdictions if we're going to be ramping up all this HIV testing and resistance testing and other kinds of screening that needs to happen as a component of PrEP. The second big area after defining the core system capacities is the required infrastructure supports. What's it going to take to support the system that successfully does that? In here, we've already talked about partnerships, public-private partnerships, coordinated data collection and evaluation, physician training, and a number of other sort of infrastructure support components. And my big thing, and I said it once in a comment, and I'll say it here again because I've got the mic, is that CDC and HRSA need to talk about the coordination of their investments in the care and treatment of people living with and at risk for HIV. So that's my little tiny advocacy moment. Because if we can leverage those critical federal investments, and they are vital and they are deeply appreciated by the states and jurisdictions, if we can explicitly leverage them and stop having to answer the question of who's positive and who's not, I think there's no end to what we might be able to accomplish. And lastly, I think all of us and many others need to agree on what the parameters of responsible implementation of PrEP looks like. And I remember, and I was talking to a colleague from Massachusetts about how when antiretrovirals, when Crixivan we first said, wow, Crixivan works, now let's make sure everyone gets it. People said, yeah, everyone but injection drug users because they can't be adherent and there'll be lots of drug resistance and it'll be a problem. Now, we didn't tolerate that argument for very long, and the concerns I'm hearing about drug resistance and PrEP, I'm reminded of those years back then. And I want to be really, really cautious in thinking about what the real risks of resistance are, and other kinds of parameters around responsible implementation that we need to be thinking about, because I believe that there's a lot we can accomplish without sort of being overly concerned about pieces like resistance. And lastly, we need to think about making access to medications for prevention a reality, and also remember about the ADAP crisis that we're currently dealing with for people living with HIV. Thanks, everybody.
Thank you, Dawn. I actually think you went to less than 6 minutes. So let me turn it over to Linda.
Thanks. I am one of a number of FDA folks who have been listening with great interest to the discussion today. And we really appreciate the forum, just to sort of get this out here. We appreciate that the forum was willing and able to conduct this conference to give us the opportunity to hear everybody's opinions on what the key issues are and how we might address them if this comes to regulatory review. I think that one thing I have to remind people of is that the FDA has a fairly limited scope of what our authority is. Our mandate is to review scientific data for a proposed indication And if the data support it, approve drugs in such a way that we can be assured that they are safe and effective for their indicated purpose. It is not the FDA's mandate, and we really have no jurisdiction over how drugs are paid for, how medical programs and policies are implemented, or many of the other things that are really critical to use of any prevention strategy. So just, we have to sort of focus on our narrow little piece of this and sort of look at things in that context. I think the earlier part of the discussion today, which focused on safety, was really very interesting, and it was pointed out that we look at a risk-benefit assessment for any drug review, for any indication. In this case, we know that we have to have a very cautious approach to the risk part of that because we're talking about use of a product in otherwise healthy individuals. And we have to be certain that we understand the benefit across different populations. And that's obviously the benefit side of things. In that analysis, we look at both what we know about the short-term and the long-term toxicities of the product as compared to the potential benefits. And I agree with somebody in the earlier panel today, I think it might have been Dr. Sag, who said that, the first thing that's going to make headlines is when somebody who's an otherwise healthy person develops fatal ATN or, I can think of drugs that previously weren't described who had Stevens-Johnson syndrome and healthy people got very bad complications of drug use. So we have to think about all of those things as we move forward and try to build into our thinking how we might mitigate those risks, as was pointed out by Carolyn's talk earlier today. I was also glad to hear that the clinician from Drexel, I think it was, mentioned the 076 perinatal transmission study. I remember being on the protocol development conference calls for that protocol, and they were stretched over a number of years because people were terrified that prevention strategy was going to have unintended bad consequences for uninfected infants. And so it's not a dissimilar way of thinking about things. Now in hindsight, it turned out to be one of our most effective prevention strategies from a biomedical perspective. So I think I'll quit because I talk slow and I'm probably over 6 minutes.
Okay, thank you very much, Gina. Can you finish up for us?
Okay, so briefly, some of the things that I thought of today as the day went on, from my NIH hat, looking at issues that require additional research. There are some gaps that I think still require research, some of which is already ongoing, thankfully. We still have questions about the efficacy in heterosexual women. And so hopefully the ongoing VOICE trial will help answer that. As one of our investigators in Uganda said, that VOICE may be the tiebreaker. But hopefully we will get the information we need there. The issue of tenofovir or tenofovir and tricytidine. Partners provided us some information on that and will continue to provide some additional information on that as they go forward with their participants remaining randomized to the two active drugs. And VOICE will provide some additional data on there, but may not be enough additional data even between those to make a scientifically based decision between those two products from the safety and efficacy standpoint. So other factors may come into play in making decisions there. One of the things that's not been discussed as much today, has been mentioned a bit, is the issue of oral versus topical. And this is an ongoing area of development, both for women and for men who have sex with men. And so there is quite a bit of research to be done there in the topical area that is going forward. And over the next several years, we'll provide additional information on that. There are a number of special populations for which we really have no data right now. Individuals with chronic renal insufficiency or hepatic disease, they're all excluded from the clinical trials, so we really don't know anything about safety in those individuals. Adolescents are likewise typically excluded from the clinical trials. There are some bridging studies that are being planned there, and we will need specific bridging studies also for renal and hepatic disease. And I would argue that these probably should be done very carefully and cautiously with providers who have expertise in these areas and not be part of more general trials where they might not be watched as carefully. And then for women, there's certainly the issues of pregnancy, lactation, menopause, and perimenopause, all of which have great impact potentially on both safety and efficacy. And, of course, with pregnancy, safety for the infant, and lactation, safety for the infant as well. NIH is supporting some of the efforts in this area, and there's others who will be doing some of the menopausal work. But there's certainly more research that needs to be done here, and again, needs to be done very cautiously because one bad outcome in a somewhat haphazardly done study could really destroy this for the field. With regard to implementation, the thing I took away from the conversations about that is to really make some decisions about what direction to take. One direction would be sort of to decide how to regulate use, and then based on that, decide who should be the prescribers, and then based on that, decide how to reach the target populations. The other direction would be to decide how to reach the target populations, and based on that, figure out who should be the prescribers, and based on that, figure out how the regulations need to go. And they both have pros and cons, and I've heard both sort of discussed today, so I think that's something that needs more discussion and more thought about how to best make that work. And the other, I think, key thing that I took from all of the discussions today is that it would be quite possible to regulate PrEP out of utility and make it too hard to implement. And so it's important to balance the need for safety, the need to avoid negative consequences like acute renal failure, like sweeping resistance, but yet make it something that could feasibly be implemented in the healthcare system that we live with today.
That brings me to the point that I think the forum staff and our meeting planners, David and Ann, have, I need to thank them for having helped us here. And frankly, the participants at this meeting, both the audience, the people on the webcast, and our panelists and speakers. This meeting would really not be possible without an incredible amount of effort and dedication on their part, as well as emotional commitment to this issue. And finally, I think we all owe a round of applause to Veronica Miller for even thinking of this meeting and bringing us all together. And with that, I'll adjourn the meeting with a round of applause.